I'm Sally Lambert. I'm a psychiatrist and I'm wanting to talk about 3 different anxiety disorders today: social anxiety disorder, generalized anxiety disorder, and panic disorder. And I want to talk about the assessment and management. The reason being is that there have been some recent clinical guidelines released by the College of Psychiatrists that are really comprehensive. I think there's 70 pages, and it's just good to be across new treatments and up-to-date treatments for these very common disorders. For this talk, I'm going to use the term anxiety disorders to denote the 3 disorders, even though in reality there's other anxiety disorders that we're not talking about today. First, I'll just discuss some of the diagnostic challenges associated with the anxiety disorders for a busy GP, and we might talk about how we can overcome them. We'll talk a little bit about assessment and then really focus on kind of management of the anxiety disorders. So first thing to remember is that anxiety is a normal response to stress or trauma or a threat, and it's actually quite helpful in a lot of cases. When anxiety becomes a disorder, people experience 3 things: high levels of autonomic arousal, unhelpful cognitions are the second thing, and the third thing is then maladaptive coping strategies to manage that anxiety. And it's the distress and disability that really makes anxiety a disorder. Anxiety disorders are the most common class of mental disorders, and 1 in 7 Australian adults live with one of these anxiety disorders. Interestingly, social anxiety disorder is the most prevalent of the 3, followed by generalized anxiety disorder. So to talk now about some of the diagnostic issues, fewer than half of people with anxiety disorders present to a health professional, and only a third who do receive minimal adequate treatment. One possible reason for this could be related to comorbidity with physical and mental health disorders. Anxiety disorders really frequently have comorbid substance use, mental health or physical conditions. And actually the relationship gets even more complicated because patients can present with physical symptoms that might suggest, say, a cardiac cause, but the problem is anxiety. Or they could be presenting with anxiety and it's actually caused by an underlying physical cause like hypothyroidism. Or commonly, there's a bit of both going on. If you suspect an anxiety disorder is at play, a good comprehensive screening question is: do you feel nervous, anxious, worried, keyed up or on edge at the moment? The next step, I think, is something that is often not done, and that's discriminating between the 3 disorders. I think the easiest way to do that is just to ask about the underlying thoughts that the patient's having. So in social anxiety disorder, patients are worried about negative evaluation from other people. In generalized anxiety disorder, they're worried about anything and everything. And in panic disorder, they're actually worried about having a panic attack or about the consequences of the panic attack. Turning now to the specific disorders, and let's start with social anxiety disorder because it's the most prevalent. Consider this as a diagnosis if somebody says, people make me anxious, or I hate going out. Primarily, it's about a fear of negative evaluation from other people, particularly in social situations. But a lot of the disability is because of avoidance, which is a strategy to manage the anxiety. The onset is really young. It's actually, the mean age of onset 13 years old. The problem is that there's such a long delay in seeking treatment. It's like 10 to 30 years on average. A good screening question is: do you worry about what people think of you? There can be a range of differential diagnoses for social anxiety disorder, and I just want to really focus on a couple. First, How to distinguish between social anxiety disorder and shyness is easy. You just look at disability and distress. People who are shy don't have those. The difference between panic disorder and agoraphobia is that principal underlying fear. So social anxiety disorder, the people worry about negative evaluation. In agoraphobia, people are worried about having a panic attack or not being able to escape from a crowded room. The other one is separating it from generalized anxiety disorder. So in generalized anxiety disorder, the worries are broad, reaching, and social anxiety is just one aspect of many worries. To generalized anxiety disorder now, and the clinical presentation, I guess, is that excessive and uncontrollable worry. People who worry about anything and everything, they present with somatic symptoms, so like muscle tension, feeling keyed up, or gastrointestinal system. It's often comorbid with major depression or other anxiety disorders. And a good screening question is, do you think you're a worrier by nature? The art in making the diagnosis in generalized anxiety disorder is often to shift the focus of the worry. So the patient might present with the worry of today, and it's about shifting the focus from that particular worry to their worrying in general. I just want to hone in on one differential diagnosis for generalized anxiety disorder, and that is separating it from a person who presents with major depression with anxious distress, because they can often be quite hard to tease out. And the way that you do that is by asking about their thoughts, their underlying thoughts. People with major depression can sometimes be more focused about the past and things that went wrong in the past, whereas people who have generalized anxiety disorder are more focused on, possible future catastrophes or the here and now. And also, if a patient's presenting with other symptoms of depression like low mood, anhedonia, etc., think major depression. To panic disorder now, approximately 1 in 3 people will experience a panic attack in the course of their life. It doesn't necessarily mean that they have panic disorder, especially if someone's over-caffeinated or hungover or going through a stressful time. A panic attack can occur and never come back. Panic disorder is when someone presents with these sudden, unpredictable episodes of severe anxiety that peaks within a minute or so, and it's associated with lots of physical symptoms and fear of possibly dying or something catastrophic happening. In panic disorder, it's the persistent worry and the change in behaviour to avoid having more panic attacks that can cause disability. A good screening question is, do you ever get really severe anxiety that comes on abruptly and possibly out of the blue? In panic disorder, the median age of onset is around 30 years old. I would advise being really suspicious of an organic cause rather than thinking panic disorder if the person is over the age of, say, 45. Turning now to the assessment of the anxious patient, and just a couple of things about managing the anxiety in the room. One is that when a patient comes with an anxiety disorder, it's really important to think, it's probably a really difficult conversation for that patient who might be feeling a sense of shame about some of the things that they do in response to the anxiety, or even if they have social anxiety disorder, worrying about what you think. It's really important to appear kind of open and empathic, but one thing too is to remember to validate how awful it is to sort of live with anxiety. So, for example, if someone's having a panic attack, they often think they're often convinced that they're going to die, and that would be absolutely terrifying. So I think it's really important to acknowledge that, so that the patient doesn't feel like they're crazy for fearing another panic attack. Another good tip is that patients who are anxious, that sometimes really keen for you to know everything, because every single detail of what's going on, because they're anxious and they're perfectionistic and they want you to know. And it's important to make them feel heard by just simply summarizing some of the salient points back to the patient in a calm way. And that can sort of help streamline their history as well. If you have a patient who has really severe anxiety in the room, and you're finding that they're really quite distressed, I've got 2 techniques that might be helpful for de-escalating some of the anxiety. One is a breathing technique, and what you do is you explain the technique and then you actually do it with them. So you say, okay, I want you to breathe in for 4 seconds, hold your breath for 2 seconds, and then exhale for 6 seconds, and you do it with them. And you can continue to do that until they start to feel a bit more calm. Another one is if you really just want the patient to sort of come into the room with you, into the here and now, where it's a nice, calm, settled environment. The technique is called grounding. And what you say is, okay, you're here in the room with me. I want you to name 5 things that you can see in this room right now. And then you go through, I want you to name 4 things that you can hear right now, 3 things that you can feel. You know, it might be your watch band or hair on your cheek or something like that. I want you to name 1 thing that you can taste, for example. So you're bringing the patient into the room, and it's a good exercise because you can illustrate to them that actually there's nothing life-threatening happening here now. Okay, the third thing to remember about managing an anxious patient is managing your own anxiety, because it can feel contagious sometimes, and you might really want to help someone who is appearing really distressed and upset. It's important to remember a couple of things. One is that even though you might feel anxious, appearing calm is really, really helpful for the patient. And the second thing is that these are chronic illnesses, and the effective treatments take weeks, probably months to work. So you don't need to do anything right now. You might need to manage risk or manage a situation, but you don't need to make a really definitive diagnostic decision right now. So hold off on anything that makes you feel uncomfortable, like prescribing a sedative medication or over investigating with, like a full body PET scan or something like that in response to anxiety symptoms. In terms of suggestions for medical evaluation of the anxious patient, it's important to do a systems review and to do a fairly broad physical exam: cardiovascular, respiratory, neurological, endocrine, gastrointestinal system. And once you've done that, some basic bloods like full blood count, EUC, LFT, thyroid function test, calcium, magnesium, phosphate, and anything that you want to explore having found something abnormal in the systems review or the physical examination. You might want to do an ECG, especially if there's cardiac symptoms. If there's nothing else to suggest there's anything wrong, that's enough. Once you've arrived at a possible diagnosis, something really helpful is a rating scale, because you can, at that point, give it to the patient to fill out. There's a bunch of freely available rating scales, and you can then ask the patient to fill it out again when in a few weeks or months, when you're assessing how effective a medication has been. On the screen, it's the GAD-7, so it's assessing generalized anxiety disorder. And as you can see, patients are asked to just rate how frequent their symptoms of generalized anxiety disorder are, and then rate their disability or their ability to function. These rating scales are all freely available. You simply need to Google them. Turning to management now of anxiety disorders. And I want to talk about psychological interventions and pharmacological interventions. So we'll start with psychological ones. The main psychological intervention is cognitive behavioural therapy because it's been studied more than the other psychological therapies and it's supported by numerous meta-analyses. And it's been shown to be effective. In the studies, 8 out of 10 study participants will have a reduction in their symptoms, and 5 out of 10 will have such a good reduction of symptoms that they no longer meet criteria. So they essentially recover. The other thing is that after they recover, they often stay well. CBT involves a couple of different modules. It's usually a 12-week course, and it would start with education about the condition. So patients would understand something like that a panic attack isn't lethal, or that avoidance of social situations can often make those social situations more scary in the future, for example. Another module is the management of the fight or flight response using techniques like we've already seen today. There's graded exposure, which is often the part of CBT which patients find to be quite difficult because what it does is it gradually exposes patients to their biggest fear. So for example, if I really can't go shopping because I have social anxiety disorder, I can't get to the shop, it might start with imagining that I'm going to the shops and feeling the anxiety that's associated with that and tolerating that, and then slowly building up to me going to the shops at the most busy, awful time, like Christmas Eve. Another module is the safety response inhibition module. So that is where, if in response to anxiety, patients have these safety behaviours, which are again a maladaptive response to the anxiety. An example might be if I have generalised anxiety disorder and I'm going to the park with my family, I might actually miss out on going to the park because I'm packing for every single possible scenario: rain, hail, windstorm, invasion, etc. And so the family doesn't get to go to the park. So that's a safety behaviour, and I need to learn to inhibit that safety behaviour. There's also the module of cognitive strategy. So that's learning how to problem solve, for example. CBT can be delivered with a therapist, like a psychologist, in a face-to-face delivery, but there's also digital CBT or online CBT courses now, and there is good evidence that they are effective and in fact could be just as effective as a face-to-face deliveries. These are some of the resources for digital CBT that you can point patients to or you can use yourself. So Mental Health Online is good for panic disorder. Mood Gym is good for generalised anxiety disorder. This Way Up is good for panic, social anxiety and generalised anxiety disorder. And this one, MindSpot, is good for people with more complex presentations, so maybe someone who has comorbid anxiety disorders or comorbid depression. With any treatment, there's adverse effects, and there are adverse effects with CBT. Like I was saying, some of the modules that challenge these defense mechanisms and adaptive behaviours that patients have in response to anxiety are actually quite anxiety provoking. So patients drop out of those at that point in those modules, and they might say, oh, actually, CBT made me feel worse. It might mean that the clinician delivering the CBT was going too fast or something like that, but it has, I guess it has the effect of demoralising the patient or making them feel like their problem's treatment resistant. Overall though, the body of evidence suggests that there's no serious adverse reactions to CBT. I think one of the problems for GPs is that you're sending patients off to multiple different private psychologists and you don't really know if they're doing CBT or they're doing it properly. So a good way, A good way to assess fidelity of CBT is to ask, what are you doing for your homework? Show me some of your breathing techniques, or are you doing some graded exposure yet, or something like that. Turn now to the pharmacological interventions. The cool thing is with these guidelines, for the 3 disorders, the first few steps are all the same. And what we know for all 3 is that SSRIs are the first line. They're pretty effective. In fact, they're on a par with CBT, so 5 out of 10 people who take them will get better and recover. They're also the best tolerated of the psychotropic medications for anxiety. SNRIs, such as duloxetine or venlafaxine, have similar efficacy rates, but their side effect profiles a little bit more difficult to tolerate. So while they are also first line medications, they're kind of less first line than the SSRIs. The guidelines say that if you're going to start prescribing an SSRI or first line medication, that you also prescribe, if you don't do CBT, some graded exposure like I explained. So which SSRI to choose? Overall, evidence doesn't indicate which one is preferred or more effective, with the exception of generalized anxiety disorder, which I'll talk about later. So you choose it on the basis of the individual patient. They might have had experience with one before that was helpful, or you could talk to the patient about some different options and they can choose the SSRI that has the side effect profile that suits them the most. Finally, choose one that you're comfortable prescribing as well. Some practice points with the SSRIs and SNRIs. You really need to manage the fact that the treatment for anxiety disorders makes you feel more anxious in the first week. So you need to manage that initial anxious drive or feelings of agitation or gastrointestinal symptoms that settle down after a few days. But in an anxious patient, they tend to really feel this more than in depression, say. Ways to manage that is through really careful and clear education about the adverse effects and the fact that they're not going to harm the patient. And start at a really low treatment dose. So actually half the dose of a starting dose for major depression. Once you start low, you go slow. So you titrate really, really slowly. Another practice point is that patients need to know to take them every day and not to take more when they feel more anxious. They also need to be aware that they might not see a therapeutic effect for 4 to 6 weeks. Sometimes actually it takes up to 12 weeks for an effect to be noticed. The good news is that response rates can, even after 12 weeks, slowly, incrementally improve for up to 6 months. So your initial treatment steps are 1, CBT alone, 2, medication alone, or 3, medication plus CBT. And the guidelines suggest in milder forms, CBT alone is great. In moderate forms, you can choose either of those 3 options. And in more severe forms, you go CBT plus medication straight up. While it's important to monitor the patient regularly, possibly every few days, maybe once a week when you first start the medication, you can't really assess response until the 4 to 6 week mark. So at the 4 to 6 week mark, if there's a partial response, that's good. You're probably not going to expect a full recovery at this point. So at 4 to 6 weeks, if there's a partial response, continue to monitor, watch and wait, and don't change the treatment. If at 4 to 6 weeks there's an inadequate response or no response or there's distress, you've got a couple of options. I guess you're going to modify the treatment according to your initial option. So if you decided on digital CBT, you might change it to face-to-face CBT. If you did face-to-face CBT, you might add medication or increase the frequency of that CBT. If it was a medication option that you started, you might increase the dose of the medication. If the problem is that the SSRI isn't tolerated, but it's effective, the guidelines suggest switching to a different SSRI. If that second SSRI isn't tolerated, the guidelines suggest switching to an SNRI. Okay, so you've done those things and you assess the response again after 4 weeks of that change. And if at that point there's still continuing distress and inadequate response, you have some options. But before you make some changes, you need to review the diagnosis. You need to recheck for comorbidities or complicating factors. For example, things like personality disorder, substance use disorder, major depression, or physical problems. At that point, you make sure that there's both psychological therapy and medication happening. You might increase the frequency of the CBT sessions. You might consider switching the antidepressant at that point. But you also might consider obtaining a second opinion. To social anxiety disorder now. So if there's continued inadequate response to the SSRIs, SNRIs, you can consider a couple of specific medications. Treatment with a monoamine oxidase inhibitor, for example, phenelzine, a treatment trial with pregabalin or gabapentin, or a treatment trial with a benzodiazepine that is short and regular. Meclobamide is also another treatment option for social anxiety disorder. Mirtazapine is a good drug to talk about because while we often feel like mirtazapine is a good medication for anxious patients, it's been shown mostly to have no benefit in social anxiety disorder. Same with the antipsychotics. The jury's out with regard to efficacy, and because the side effect profile is so burdensome for patients, the guidelines actually say that there's not enough evidence to recommend them as a treatment option. Other guidelines from overseas, I think, consider them a bit more, but antipsychotics in social anxiety disorder are very controversial. Beta blockers are also something that we commonly prescribe, but the guidelines say for social anxiety disorder, which is like a broad range disorder, beta blockers aren't particularly helpful. I think they have been shown to be helpful if the anxiety has like a narrow focus to specific situations. So for example, like a registrar doing a clinical exam or public speaking or something like that. But with the general social anxiety disorder, they're not recommended. To generalized anxiety disorder now, and it just should be worth noting with this disorder that there are other psychological therapies aside from CBT that are helpful. Psychological interventions like mindfulness, acceptance-based interventions, exercise therapy, and psychodynamic psychotherapy are all options that have an emerging evidence base. To the specific medications that you might consider, third, fourth line treatments for generalized anxiety disorder, duloxetine and sertraline showed the greatest benefits on symptoms. Escitalopram and venlafaxine achieved the highest remission rates, and sertraline and pregabalin showed the best tolerability. Agomelatine, especially if medication isn't tolerated, because agomelatine is quite well tolerated. So these specific medications might be helpful in this disorder. They can be options to think about in specific situations, like if a medication's not tolerated or the patient's having relapses. Again, quetiapine has been shown to be modestly effective in this condition, but the side effect profile precludes recommendation by these guidelines. Imipramine, which is a tricyclic antidepressant, has been shown to be effective. Again, it's a tricyclic, so there's cardiac toxicity, lethality and overdose, amongst other side effects that are more toxic than, say, the SSRIs. Beta blockers are, again, not recommended by the guidelines. Finally, the guidelines also talk about that short-term trial of regular benzodiazepines should other treatment options fail. To panic disorder now, and I should just highlight with panic disorder that the patients with panic disorder are particularly susceptible to the adverse effects of medication. So these guys are definitely people that you need to start very low. And I often advise my patients with panic disorder to buy a pill cutter and start on a quarter of a tablet and go again, really slowly. In panic disorder, looking at the third, fourth line medications, MAOIs or monoamine oxidase inhibitors are effective in managing symptoms, but their use is limited by their safety and tolerability profile. Same with imipramine and clomipramine. And remember that in panic disorder, higher daily doses may be superior to lower doses for some antidepressants, such as paroxetine and fluoxetine, but not for others, such as citalopram and venlafaxine. Again, the short-term treatment trial of benzodiazepines can be an option if other treatments have failed, but this needs to be done cautiously. Interestingly, in panic disorder, findings from fixed-dose RCT trials found that there is a dose-response relationship for some medications in panic disorder. So higher daily doses might be considered for antidepressants like paroxetine, fluoxetine, but not for others, for example, citalopram. Again, I think it's really interesting to note that beta blockers aren't recommended by the guidelines in this disorder either. I just want to briefly touch on an aspect of the CBT for panic disorder in particular, and that is there's a component called interoceptive therapy, and that's where the therapist will expose the patient to the physical panic symptoms. So they do things like spin them around on a chair or get them running on a treadmill or get them to hyperventilate in order to start off having those somatic symptoms of a panic disorder. So that's another thing you can ask about to test. Finally, I just wanted to talk about how you might approach a patient with treatment refractory anxiety disorders. So this would be after you've sought a second opinion or referred to a psychiatrist and you're still managing a patient who has these anxiety symptoms and nothing is working. So the first thing you need to do is reassess your treatment expectations and modify them if that's appropriate. And when you've done that, it's important to discuss treatment goals with the patient in a collaborative way. When you're getting to this point, it's important to trial one intervention at a time so that you can figure out what it is that's actually causing an improvement or making things worse. The other thing that can happen at this point is tricky therapeutic relationships. So it's important to ensure that that patient's seeing one provider and that they're seeing them fairly frequently, but not too often. If you're feeling a sense of hopelessness or uncomfortable feelings about that patient, that you discuss that with other clinicians involved in their care or a supervisor. These might be entirely normal and appropriate reactions to a situation where you feel kind of helpless, but it's important to sort of seek supervision and keep those feelings in check. Finally, consider maintenance, rather than CBT, consider maintenance or supportive psychological therapies if the patient's finding them helpful.
Welcome to our educational series in mental health. This is brought to you by ProCare, who are providing clinical services to the GP Psychiatry support line. I'm very fortunate to have a colleague of mine, Sally, here today. Hi, Sally.
Hi.
So, I'd be really interested in finding out your opinion as to what the processes a GP should work through when a patient walks in the door and they suspect they have an anxiety disorder.
Well, one thing that's really important for GPs is to engage the patient in a supportive therapeutic relationship. And that might be as simple as appearing calm in the face of quite a significant degree of anxiety in the room, validating the awful experience that anxiety can be sometimes, and also being clear about what treatments have an evidence base and what a patient can expect from treatments for anxiety. Mm-hmm. I think it's important for the GP to get a bit of a sense of who the patient is, a bit of a context and longitudinal history, what they were like before the anxiety. The anxiety could have been chronic, it could have emerged when the patient was a child, but it could have also emerged 6 months ago. And the person there got in their room might be significantly impaired compared to what they were doing 6 months ago, which was working a high-powered job and managing lots and lots of things and being a really perfectionistic person. So it's important to get a bit of a context for that. Getting a sense of comorbidities is important, and teasing them out, as in, is a physical health problem at play here, or is this purely anxiety, or are they coexisting? And if so, what needs separating, what needs treating, and what needs investigating without causing alarm? And I suppose assessing risk and comorbidities like substance use and managing those, and appropriately referring when things are severe, or when the patient has failed some treatments, for example.
Okay. And so, I mean, you spoke about separating out organicity and I guess an endogenous or anxiety disorder. So what kind of things should a GP order in terms of a first line raft of investigations?
Well, I think it's important to do a physical examination and a systems review first, and then you can decide if you need to go beyond doing basics. But if nothing is suggesting that there's any problem, a good basic battery of bloods is full blood count, urea electrolytes, liver function tests, thyroid function tests, blood glucose, and it's often a good practice to do an ECG as well. Okay,
all right. And oftentimes people are not that forthcoming when they talk about their substance use, and oftentimes when people are anxious and they might have their own reasons for not wanting to disclose how much of a substance they're using. So what techniques do you use to actually engage a person and pull that information out of them so you can develop that comorbidity picture?
Well, when I'm taking a history and forming a relationship with the patient, I try to make it pretty clear that they can tell me things, and I'm okay with that, and it's okay. There's nothing abnormal about that. It's what people do. So making patients feel at ease by telling you things. Yeah. Sometimes when I start taking a substance use history, I might say, when people are really anxious, they're often looking for things that will relax them. And there's a bunch of drugs that relax people initially, like alcohol or whatever. And I might say, do you ever use that as a technique for managing your anxiety? Okay. Rather than say, do you use drugs?
Yeah. So you create an environment where a person will feel comfortable and they can actually contextualize minimizing their symptoms. So it gives them an explanatory model, doesn't it?
Yes. Yeah. Yes.
I guess, so oftentimes we'll see a person come in and they'll expect something there and then. Mm-hmm. So what advice would you give to a primary practitioner in terms of what to kick off with in terms of prescribing?
Effective treatments for anxiety disorders take weeks to months to really even noticeably have an effect. So you're not going to be able to actually treat anything definitively that day. Mm-hmm. It can be helpful for a patient just to come to see a doctor, and to have a label put on what's going on, if that's an appropriate thing to do, and to have an idea about treatments. Like I was saying in the lecture, like the treatments are pretty effective. There's a pretty good chance that if you start a treatment, you're going to get better, but it's going to take some time. So I think that can ameliorate a lot of anxiety. The cruel thing about some of the medication treatments in anxiety disorders, the SSRIs and the SNRIs in particular, is that they often actually mimic symptoms of anxiety, or they make the anxiety worse initially.
Yeah.
So it's important to talk about that and to give some education about the fact that even though the anxiety and the symptoms feel worse, there's no physical harm that will come to you because you're feeling tachycardic or anxious, or you're not sleeping. I talked about some techniques in the lecture. So the technique of slow breathing, and doing that with the patient, like staying calm, doing a breathing exercise or a grounding exercise can be helpful. And I think it's not only helpful in that it slows the person down and it kind of charges the parasympathetic nervous system and gets that sympathetic drive to sort of peter down, but I think it also shows that you're sort of willing to sit with the anxiety and hold it. So that can be helpful as well. So in some patients, it's appropriate to give a short course of low dose benzodiazepines, especially if you're starting an SSRI. But these would be patients who don't have substance use problems, and patients that you can follow up in the next day or two to see how they're traveling. If it's a concern, if you're really concerned. I think if you have a concern that risk is going to emerge, so in children and adolescents, when you're starting a medication, there's been an association with SSRIs and treatment emergent suicidal ideation or behaviours. So it's important to make a plan about that, and if necessary, refer to a community mental health team or to hospital to manage.
So referral to a specialist is often a difficult thing to judge because, as you've mentioned, it can take a while to get a treatment response. So I guess what advice would you provide to a referrer as to what are the key temporal or clinical points at which you'd really want to make sure they saw a specialist?
Yeah, sure. So if a person's really severe and there's risk and there's comorbidity, and you're thinking, well, this is the first time I've seen this patient, or this is the first time I've had to do anything about this anxiety, I think this patient is complex enough for me to send to a specialist now. Do it because you can get that referral in place while you're starting initial treatments and the workup. I think it's important as a GP to do, like we talked about, the physical workup and just and manage the comorbidities. Once you're comfortable, you can start first line treatment. Refer to a psychologist to do some CBT, and if you think it's necessary, start an SSRI. Start with if you have a good sense of a diagnosis, say generalized anxiety disorder, you can give the patient the GAD-7 to do, and then by the time they get in to see a psychiatrist, they might have had 7 weeks on treatment. They can reassess the symptoms at that point. If you think there's a significant degree of risk, and you want the patient to have a timely assessment with a public mental health team, it's a good idea to be really clear about your concerns about that risk, and to kind of make that very clear in the referral. It might also mean calling and sending a letter, and just sort of highlighting your concerns about this patient. Okay.
And so if somebody was referring to you, what would you like to see in the referral?
I'd like, I know it's difficult sometimes to know exactly what's going on diagnostically, but it is good to know the history of presenting complaint, the onset, duration of symptoms, severity of symptoms, what might be going on that made this problem occur to this particular patient at this point in time. If you know the patient well, it'd be really good to have that conveyed to me. I think sometimes GPs, they treat families, and so if the GP happens to know that the whole family has this similar problem, that's good to put in the letter as well. So giving a bit of context to the patient, it can be helpful. It's helpful to know basics like the investigations that you've done and the comorbidities and medical problems and the treatments that have been tried, for how long, at what doses, why they failed, why the patient didn't like that particular treatment, for example. What they might have been referred for CBT but didn't like it or didn't like the therapist. And I think one thing that makes a really, really good referral letter is if a GP can comment on why relationships with therapists might have failed, or problems that the patient encounters in forming a therapeutic relationship. That's a really nice thing to see in a referral letter.
When a patient walks through the door in your clinic and they've maybe had a trial of an SSRI in the past or one or two SSRIs in the past, and we would see more complex patients often, and there's a history of comorbidity, and let's say there's a history of substance use, what kind of protocol would you put in place in terms of ameliorating side effects from medication or helping to at least quell some of the anxiety symptoms whilst you test out further pharmacology?
I think patients who have a history of addiction problems or dependent problems, it doesn't mean that they shouldn't have benzodiazepines, for example, because they still suffer. And they suffer, it's awful. It's awful to be anxious. We don't want anxiety. We don't want needless anxiety. But I think things that you could do to kind of manage risk, because what I would worry about, for example, if I was sending someone who has a history of substance abuse or substance or addiction problems, if I was sending them home with some benzos, I'd be worried that there's a risk of accidental overdose. I'd be worried that they would be using them perhaps not as prescribed, or I would worry that it could be part of taking more a bigger picture of benzodependence, for example. So to manage that, I suppose I would be seeing the patient more frequently, and I would be giving them very small prescriptions of the medication. So, for example, I might even send the script to the pharmacy that they choose and have a word to the pharmacist and say, could you dispense this medication daily? So things like that, and being pretty open with the patient about my concerns of doing, and sort of explaining that I just want to do no harm.
Thanks for that. So it is complex, but you can put a framework around how the benzodiazepines are used and how they're managed, and pharmacists are great allies.
They are. I've only had really positive experience with pharmacists.
And so let's assume that you have a patient who you've met for the first time and there are risk issues. Can you give us some guidance on your thinking in relation to what kind of safety plan you develop and what you'd be thinking about when you're developing a safety plan, where you're sure that the patient will be safe at home, but there's a level of risk there?
Okay. So say I have someone who presents with generalized anxiety disorder, and they have a history of when they start medication, having some suicidal ideation and a history of suicide attempts in the past. So I'd explore with that patient what their experiences of suicidal thinking and attempts were in the past, and what happened and how they kind of lost control and how they reflect on that now. And I guess together we could hopefully come up with a plan for, in a way, I guess it kind of highlights to the patient that if we make a plan, we can have a sense of control over this situation now, and it can sometimes make people feel kind of positive about moving forward.
Yes.
But just talking about some early warning signs, and having a list of people that they can talk to, like friends or family, and even highlighting those people in their phone, or wording up those people beforehand to say, look, I'm a bit fragile at the moment. Can you keep an eye out for me?
Yeah.
I might even encourage a patient to bring a person into the room so that we can collaboratively plan together. And then there's worst case scenario planning. So talking to a patient about what, how they would, if they need to go to hospital, how that might, how the mechanics of that might happen. You know, like, would it be helpful for me to write a letter for them to have, or would it be helpful for them to come with their mum, or would it be helpful for them to go to a private hospital or something like that? It's also important to give patients a list of numbers that they can call, like Lifeline or the emergency mental health line.
Yeah. I actually have a sheet of paper where I have those numbers, and I get people to take a photograph of that and pop it in their phone. And people find that quite effective as well. Sometimes apps have a place as well, so relaxation apps and those sorts of things. Do you have any particular tips for what you might find helpful or what you've recommended to people?
Well, the digital CBT, This Way Up Clinic and Mood Gym, and stuff like that, they're evidence-based CBT. They're amazing. They're actual treatments, and it helps.
Okay, so we've spoken a fair bit about what we should do when somebody walks in the room, how to help them if we need to develop a safety plan, some thoughts about medication, and giving people advice about the exacerbation of the anxiety-like symptoms when you start medication. What to think about when you refer somebody to a psychiatrist, but also when to think about moving a person quickly to public mental health services, because there's risk there and you believe the risk exceeds their safety in the community, so that they won't be safe in the community. Once you've stabilised somebody's symptoms, and let's say they have 80-90% symptom amelioration, do people need to stay on medication forever?
That's a good question that hasn't got a clear answer. Actually, even the guidelines don't give cut and dried answers that sort of fit everyone. But essentially, a patient should stay on medication for at least 12 months after an anxiety episode. What we know is that the relapse rates are higher for patients who have been on medication and who stop medication compared to patients who do CBT and have and get better. So if this is the case for a patient, like they have 12 months of sertraline, say, and they relapse, you can then have a conversation with them about whether or not they would like to do CBT or to go back on medication, but just to go on medication for longer. And there are some patients who have what's called maintenance medication, which means that they essentially go on medication all the time to prevent relapse.
So it's a vexed question because really there are no good quality studies, because I guess we operate at a syndromal level with anxiety, and even though we have our separate disorders, we have a sense of what helps. And we've got some specifics in terms of which medications are better for which subtypes of anxiety disorders. I mean, ultimately, from what I've heard you say, psychological therapies together with pharmacotherapy is best.
Yes.
Minimum effective doses is often best, but after a prolonged period of being well. Because after all, we look at a person's level of function, and our goal is to ameliorate anxiety so that they're functioning their best.
That's right.
Isn't that right? So there are occasions where some people just don't respond to any form of treatment. And sometimes I see people who come to me and you can see that some form of process has been worked through multiple medications. What's your view on TMS and treatment of anxiety?
Actually, my view, my experience is actually really positive. So, like you say, there's only emerging evidence for TMS. But actually, I've had one particular patient who had so many trials of medication. She had an A4 piece of paper with the list of medications, and she was so perfectionistic. She'd written like the dose of medication and why it wasn't good, or what symptoms were helped by them. Like, it was a brilliant history of failed medications. And she started having TMS, and the anxiety got better. And so she's been on, she's been having regular TMS, and that's been really helpful. When medications aren't achieving what you need them to achieve, having an ongoing therapeutic relationship that you actively manage, having some good, clear boundaries and expectations and a plan, and TMS can be something that is worth a try.
Yeah, and as human beings, fundamentally, we all need to have some sense of hope that whatever it is that we're suffering from can actually be recovered.
Yeah.
Yeah, and it's exciting. The evidence base in TMS is developing and becoming more and more reasonable as a sort of last line of treatment. And I too have shared similar experiences. And then people actually only getting a treatment response to TMS. And there are many things, because we operate at a syndromal level, that we don't understand in terms of treatment response.
Yeah.
And so just keeping hope awake and alive in people, but also making sure that we don't close ourselves off and experience that transference of losing hope when people fail multiple medication trials, I think is really important.
Yes, yeah.
So Sally, look, this has been a fabulous fireside chat. I've really enjoyed today, so thank you.
Great.
And I know that our GPs who are watching your presentation will greatly value the information you've provided for them today.
I really hope so. Thank you.
Thank you.